and that's fine. Okay, okay, children, welcome to the 15th session today. And today I thought that we will start off with hypertensive disorders in pregnancy. Now, it's going to be lecture 1 today, which is quite a simple topic actually. So today we are going to talk about chronic hypertension in pregnancy. And therefore, from there onwards is the first topic. And then we will continuities as gestational hypertension, then preeclampsia, eclampsia. We'll just cover all those topics that is related around hypertension, right? So now, what is very important for all of us to understand is that pregnant women will come to us with known hypertension. Now they will what is this? Sorry, it's record. Okay. A pregnant woman will come to us and she is already on diagnosed patient. She will have a diagnosis card with her and she will tell you as she comes, doctor, I have hypertension. So therefore, it is very clear, right, to us that she has chronic hypertension. Okay, she'll be followed up at a clinic. She'll be usually under a consultant. She'll be followed up, or she may have defaulted, but she will carry with her the diagnosis of hypertension, right? And therefore, it's in a way it's very easy for us, but we need to have a look at the hypertension itself, and then we will have to get in a physician involved who is looking after her hypertension to manage the hypertension in pregnancy. So from the very start of the whole thing, we'll be having a multidisciplinary input, right? This is the first category of patients who will come to us, right? And the second category of women who will come to us are the women who are not diagnosed to be having hypertension. Okay. Now, if we look at the definitions, any woman diagnosed to have hypertension before 20 weeks of pregnancy can be considered as women having chronic hypertension. Okay. Excluding, of course, HMOL. So HMOL can cause hypertension in itself. So if the patient is having an HMOL in early pregnancy and she's having hypertension, then of course, that is not chronic hypertension. But all the rest of the women normally, we will classify them as, or we will think of them as having chronic hypertension. However, we will treat them as if they are having hypertension during pregnancy. The principles are the same. But however, in our minds, we will think, okay, this probably is chronic hypertension. She was undiagnosed. She came into the pregnancy, she became pregnant. Only then when the blood pressure was checked, she was found to have increased blood pressure. So probably chronic hypertension. The second time we think that this might be chronic hypertension in pregnancy if the blood pressure, high blood pressure continues beyond 6 weeks postpartum. Okay. And then already once we meet them at 6 to 8 weeks, and then we do a blood pressure measurement and we find that the blood pressure is high, then also we can diagnose chronic hypertension. Of course, as obstetricians, remember, we as obstetricians, what we do is if we find hypertension beyond 6 weeks, then we will refer them to a physician to look after because that is beyond our scope as obstetricians, because we look after them only for 6 weeks after pregnancy, right? Now, what is hypertension? So basically it means if the blood pressure, these are the nice guidelines, right? Different countries can have different ones, different units can have different range, but universally it is thought that if the systolic blood pressure is more than 140, and the diastolic is more than 90, then it is considered as having hypertension, right? So that is, remember. So again, let me tell you. Of course, the first category is women who are already diagnosed with hypertension and on medication, on treatment, comes to you with a diagnosis card, under a consultant, following a clinic, and basically they will come and sit down and tell you, okay, doctor, I have hypertension. So you don't need to diagnose it. So the physicians would have done hopefully a super job and have excluded all the primary, secondary causes, then everything which they will need to do, and then treatment would have been started. The second category are the women who are unaware that, but we find before 20 weeks that the blood pressure is high, and that is more than 140/90, and then and of course probably those are chronic hypertensives, and also any woman postpartum after 6 weeks, if we still find that the blood pressure is elevated, then these are probably also chronic hypertensives that require long-term follow-up. Okay. Now, why is this important? Why do we need to treat? Number one, hypertension during pregnancy can exacerbate, can become more, right? And sometimes it might not be even controllable, right? So sometimes pregnancy can cause it to fluctuate up and down. Pregnancy can cause it, even when you give drugs, it might not work. And therefore, pregnancy can change the course of the hypertension and make it uncontrollable. That is one instance, remember, when even with our maximum dosage of drugs or the combination of drugs, still if we cannot control the hypertension in these women, sometimes we will require to deliver the baby. So that is one instance where uncontrollable chronic hypertension may require delivery at any time, because the woman is at risk of dying due to cerebrovascular accidents, right? And therefore, we will have to think of delivery. But otherwise, normally, any woman, the timing of delivery is normally beyond 37, 38 weeks, which we will discuss at the end about the timing of delivery, right? So, why is it important? Number one, any woman having hypertension, chronic hypertension, they are at a risk of developing preeclampsia, right? And eclampsia. The risk of having preeclampsia is 1 in 5, about 20%, which is far higher than the normal population, right? So they can develop it. So therefore, remember, for every woman who is having chronic hypertension and is coming to you with or diagnosis of chronic hypertension, we start them on aspirin, 150 milligrams, which reduces the chance of having preeclampsia slightly. Maybe it reduces it by 15-20%, right? But however, we start aspirin after 12 weeks, 150 milligrams, which is a very small dose, which needs to be continued throughout pregnancy. Second thing is iatrogenic preterm delivery. Patients with hypertension, we tend to deliver early, right? And therefore, these become preterm deliveries. And therefore, the baby also can have problems, right? So they can have preeclampsia, they can have eclampsia, they can have cerebrovascular accidents. The baby may be born early, and therefore, with it, all the problems of preterm delivery or a preterm neonate or a baby with all its problems can be there, right? So those are the associated problems that we need to understand when you are thinking of hypertension or chronic hypertension in pregnancy, right? Now, let's just think that one of these women, right, who are having chronic hypertension comes to you with into the pre-conceptional clinic. Okay, so she knows she has hypertension. Now she wants to have a child, and she comes to you with a diagnosis of hypertension. Or more simply, if she comes to you without knowing, but coming for a general checkup to find out whether she has any problems before delivery, and if you find hypertension, that makes life far easier for us, because from there, because she is not pregnant, and we are obstetricians, right? And therefore, we will write a beautiful letter to the physician. Dear colleague, this woman is found to be hypertensive, and therefore, please investigate her, and then, if necessary, treat her. And when the hypertension is fully controlled, please refer back to us, and then we will continue with the counsel. And from our side, what we need to do is what? We need to prescribe her a proper contraception, right? Until she becomes fully controlled, and that the physician says, okay, look, she can go ahead. Okay. So therefore, contraceptives, remember, we do not give them combined oral contraceptive pills if they are having hypertension, because that might have problems, especially postpartum. And therefore, of course, we will try to give them either a barrier method or maybe a progesterone-based contraceptive until she is controlled, and then she is referred back to us. The physician will do the rest, right? Generally, what they will do is when they come to her, they will need to come to a diagnosis as to what the cause of the hypertension is, right? Whether it is a primary essential hypertension or it is a secondary cause, and then they will choose the medication. But there's one thing which we have to understand, right? There is some medication which we do not want her to have just prior to conception, right? Or after conception. And what are the things that we will tell the physician? It is preferable, or he has to know actually, that the patient is not initially started on what? Angiotensin converting enzyme inhibitors and angiotensin receptor blockers, right? These are the two types of drugs which is better to avoid right at the start of the conception, or if they're trying for the baby. And of course, the other thing is postpartum. Also remember, in breastfeeding, we try to avoid this. The only angiotensin converting enzyme inhibitor that has some evidence saying nothing much is in the breast milk is enalapril. Okay, so but before the pregnancy, it is best to, just before conception, right? It is best to avoid angiotensin enzyme inhibitor, hormone inhibitors, right? And angiotensin receptor blockers, right? So therefore, we will try to avoid these. And of course, when they come, if they come with pregnancy and they are on ACE inhibitors, or if they are on angiotensin receptor blockers, we will change those drugs into a different kind, because it has been found that number one, it can cause problems with the fetus, right? So therefore, it can be teratogenic, it can have problems with the fetus, and therefore we try to avoid them. The second thing that we avoid in medication is beta blockers. We try to avoid beta blockers because beta blockers have been found to cause what is it? That is my wife yawning. Okay, hearing all this. So the second one that has been found to cause growth restriction are beta blockers, right? So we try to avoid beta blockers prior to pregnancy. But remember, even if they are put on those for control, and when they come with a pregnancy, we will have to change these medication into more suitable ones for pregnancy. So in summary, what are the ones we have to avoid? AC and angiotensin converting, angiotensin converting enzyme inhibitors and angiotensin receptor blockers. What are the commonest AC inhibitors which we use? Normally, these are medication like enalapril, captopril. These are the ones, right? Of course, there are new ones. And then the angiotensin receptor blockers commonly used by the physicians are telmisartan, losartan, all these new drugs. There are different ones. I think there must be even new ones now because they come very, very quickly, different ones. But these are the general classes that are used. Okay. So, and of course, one drug which I need to tell you about are diuretics. of all the, if diuretics are used, the diuretic that is not indicated or should be studied is chlorothiazide, right? Chlorothiazide must be stopped because it can cause fetopathy, and it has been known to cause teratogenicity. It can make cause fetal anomalies. So chlorothiazide is contraindicated in pregnancy. If they are on it, please stop it. And it is preferable that they are not on it immediately before trying to conceive. There are so many other things that can be used. And so therefore, we had to reevaluate the medication once they come back to us, saying that they are fully controlled. However, if they are on these medication, which I told you, you might need to have a chat with the physician again and try and convert them into medication which is more acceptable in pregnancy. Okay. Then the other general things which we need to find, advise them in the preconception clinic. Number one, these are the medication that. What is the desired blood pressure that we need? Our target value for blood pressure in the preconception and also during the pregnancy is normally less than 150. 150, 100, right? Or we can call it 140, 90. So because, but the desired blood pressure, we try to keep the blood pressures between systolic between 150 and 140 at least, right? And the diastolic, we try to keep between 90 and 100, but never over 100. You understand? So if the blood pressures are very low due to our antihypertensive treatment, if the systolic is less than 110 and the diastolic is less than 70, right? Due to our antihypertensive treatment, then we really need to rethink whether we need to reduce or stop the medication for hypertension. The reason being, for the placenta to get a proper blood flow, we do not want to drop the blood pressures down too much, right? And therefore, if our antihypertensive treatment is causing the blood pressure to go down a lot, right, we can stop them with careful monitoring. Of course, we can stop them and or reduce the medication and then control it in such a way that the systolic is fluctuating between, say, never beyond 140, 145 or 150 and never beyond 100, but somewhere around 140, 90. If we maintain it like that, that would be very good. You understand, right? If it drops, think in your head that you might need to reduce or take off the medication, but it has to be done in a patient who is capable of coming to you very quickly, who is capable of checking her own blood pressures and who is reliable, and he knows that she will approach you when the blood pressures climb up again, right? So that we can have a good control throughout the pregnancy, right? So this is basically things that we need to do before a pregnancy and if the patient comes to us, right? And what are the general advice we give? These are very specific advice concerning hypertension. We look at the drugs, we tell, okay, we need to change. We look at the medication, we need to change. If there is features of non-control, of course, we need to send her to the physician, right, to reevaluate. If there are a chance of, or if we think there's end organ damage, right, due to hypertension or complications due to hypertension, we will need to send the patient for the management of these, right? Once she's managed, she comes back to us, then we need to reevaluate the medication, right, to see whether she is all right and whether the medication is all right for a pregnancy. If not, we need to change them again with the discussion with the physician. So that is about specific. But what are the other lifestyle modifications? In Sri Lanka, smoking is not a big problem. However, if she's smoking, women cigarette bonne, I don't think I've rarely met patients who smoke in Sri Lanka, but in other countries they do smoke. So it is best if you can advise them to stop smoking, because that also will cause sometimes the blood pressure to go up, right? And then other things like if they are overweight and if they come to the preconception clinic, ask them to get the BMI down or lose weight, right? And then the other thing is advice on healthy lifestyle. If they can, and of course, alcohol. Sometimes excessive alcohol usage can cause problems with blood pressure control. Then recreational drug use like cocaine, all those problems can also cause problems with blood pressure control. Sometimes it fluctuates, right? And therefore, all these will need expert input and management with the relevant specialists, which you need to detect and you need to refer them. And till then, remember, as an obstetrician, our duty is to talk to them about a proper contraceptive until these problems are controlled or sorted out. Right? Is that clear? Right. Right. I have one question. Do BP targets change during the trimester of pregnancy? Also, if there is endocrine disease, do the BP targets drop? Now, if there is endocrine disease, our blood pressure targets might drop. If there's endocrine disease, what we do is we do not wish the blood pressures to fall too much, right? So we do not want the blood pressure to fall less than 110/70. We try to keep them at a certain level because the perfusion otherwise will have problems. So therefore, targets during the trimester, usually what happens is due to the physiological changes, the blood pressures drop during the first trimester due to universal vasodilatation. And then what happens is later when the blood volumes increase, and that slowly the blood pressure climbs back to normal. So therefore, the targets do not change much, but you might need to adjust your medication depending on the thing. So the targets remain the same, right? And endocrine damage, if there is endocrine damage, it is not wise for us to reduce the blood pressure too much because perfusion may be compromised, and therefore we will need to keep the pressure slightly higher than normal. Second question is why OCP are not indicated? OCP are not indicated because of the estrogen content, right? And that can cause more water retention and then can cause the blood pressures to go up. So oral contraceptive pills can be used. There's not a huge problem, but especially we need to be very careful in OCP. It is not, remember, different kinds of contraceptives can be used, especially short term, but it might exacerbate the problem. So therefore, if she has been on OCP and she is fine and control, that's all right. But please try not to start things new, right? If we are trying to get the blood pressures controlled as a newly diagnosed patient with hypertension. Okay, then, so therefore, if she has been OCP and we are then, and if so, therefore you can continue, but you need to be very careful with that, right? Do not initiate that, and especially after delivery, also even if they are not breastfeeding and if you are hypertensive, postpartum we do not initiate oral contraceptive pills. We think of progestogen containing or other types of non-hormone like intrauterine contraceptive device or a Mirena, right? These can be used other than OCP, right? Okay, so that's all. No questions, right? Okay, now let's look at so this is the preconceptional sort of thing. Now, if you want to look at hypertension, right? Normally, about the incidence of hypertension is about 5%, 1 to 5% of chronic hypertension patients will come to you with pregnancy. So therefore, if all the pregnant women, we are looking at a portion of about 5% who comes to you. The next thing which I want to tell you is, now I have spoken at length about the patients who are already diagnosed preconceptionally. Now the second type of patients that are preconceptionally will come to you is that you will come to and then you will diagnose the hypertension. You measure the blood pressure, it's 160/120, okay? Right, so therefore, now we need to do what? We simply need to we simply need to, we simply need to refer them on after providing them with proper contraceptive advice, and maybe the general advice about the contraception, and general advice about losing weight, healthy eating, exercise, right? Consumption of alcohol, to stop recreational drugs if possible, to stop smoking. So all this general advice needs to be given at that time. Now, what are the things that we need to look for in the history if a woman comes to us either preconceptionally or diagnosed? There are a few things that might be. Now, for that, we need to understand, number one, what are the causes of hypertension in patients or chronic. We need to understand the causes of chronic hypertension. Now, how are they categorized? Number one, the most important category which you need to understand is essential hypertension, right? So here, if a woman is having essential hypertension, now remember the causes of hypertension, which are done, which you all must be very familiar, right? Because are what? You have essential hypertension and then you have secondary causes, right? Now, if the woman is having essential hypertension, right, we need to understand that, of course, when it goes to a physician, they will rule out all the causes, right? They will rule out the renal causes, they will rule out the secondary causes, whether it is essential, and you arrive at a diagnosis of essential hypertension, right, by ruling out the secondary causes. Okay, so that is the rule of thumb which you need to understand. So I'm not going to do a total lecture on hypertension for you all. I'm going to just give you an overview of everything so that you understand what exactly to look for, right? So essential hypertension, if you diagnose, right, one of the things which you might want to understand is that she may be having a family history of essential hypertension, which might tell you, okay, that this is the reason for the hypertension. Next is so those are the most of the things is a family history, and therefore once you exclude all the rest of the causes, then of course you have to arrive at a diagnosis of essential. Now, how do we investigate? Basically, investigation for essential hypertension is ambulatory monitoring of blood pressure. They are given a machine, right, which they need to hold, and it will continuously measure blood pressure over a 24-hour, 48-hour period, which they always carry with them, and it will measure the blood pressure throughout the day and record it in the machine, right? So these are the things that we need to find out whether it is essential hypertension or not. One more, sorry. Need to take call, one more. Right. Now, the second large group of hypertensive disorders, that is chronic hypertension, are renal problems. Out of all the renal hypertensive diseases, about pregnancy will come out with about 14 hypertension in pregnancy. About 14 to 15% of these patients will have renal problems, right? And sometimes these renal problems are diagnosed during pregnancy when they present with hypertension, right? So out of these, there are 1, 2, 3, about 4 causes which we need to find out. The first is chronic kidney disease, right? And in the history, sometimes you might get in these women reasons for reflux nephropathy, right? Which are, they might have had enuresis, that is, the urine passing on its own. There might have been reflux, very frequent urine tract infections, right? These are the things that they might have been there in childhood, right? Or a family history of sometimes kidney disease. So all these might cause renal problems, which can cause chronic kidney disease, right? And there is sometimes, so these renal problems in the history also can tell you, okay, there is a possibility that this woman may having features of chronic kidney disease. And what are the things that we might need to do to check them? Because of course we are not going to do it, but we can do a few things if we want and send them to the physician. Look, oh, we did this, please, look after this patient, right? You can do serum creatinine. You can do, if necessary, an ultrasound scan. There are specific scans to talk about renal scarring, for example, DMSA, right? I think I'm sure you have heard of it. These are the ones that it's a 99M, some disulfide or succinic acid or something, some long thing, right? Which for renal excretion. Then different kinds of MRIs, different kinds of where I can look at the kidney functions, right? These are the things, creatinine. Then we can check for protein excretions by different, for example, urine, protein, creatinine, the albumin ratio, right? All these can be done to check for these, and then you can arrive at a diagnosis of chronic kidney disease, which may be causing hypertension. The second cause, which we are all fond of, is what? The renal artery stenosis, right? And therefore, it's usually a fibromuscular dysplasia, as you know, where the muscle of the renal arteries have a problem, and therefore it can cause stenosis, and it is clinically found as a renal growth, which can be diagnosed. And to diagnose that, we will need to do a renal artery Doppler, right? The third kind is from renal disease would normally be what it is, renin producing tumors, which are neuroendocrine tumors, which is normally diagnosed by checking these hormones in the blood, which are specific assays. They can be very expensive, but they can. So that also is a possibility, right? And then different kinds of reflux, the scarring of the kidneys, glomerulopathies, immunoglobulin A, nephropathies, all these, also these chronic diseases, right, can contribute to renal damage. And this also is checked with very specific investigations. For example, you can different kinds of immunoglobulin A's can be checked, different kinds of immunoglobulins can be checked. So all these can be, and then of course, renal disease can present this polycystic kidneys sometimes can cause also hypertension in pregnancy. So these are the types of renal disease that might present. So these are very specific features that must be, or diseases that must be diagnosed by a physician or endocrinologist, and treatment needs to be started. So as MBBS, right, what we need to understand is as an obstetrician's point of view, and from an MBBS point of view, you need to know, just remember one major part of chronic hypertension is essential hypertension. Okay, that is number one, and that is ambulatory monitoring. The second largest group is renal, right? Chronic kidney disease, renal artery stenosis, then renin producing tumors, right? And different kinds of immunoglobulopathies that can hurt the kidney and cause glomerulonephritis, their chronic kidney disease, polycystic kidney disease. All these can cause renal problems and cause hypertension. Okay, so these are the things. And of course, drug induced. I forgot, drugs can damage kidneys, and that can cause hypertension. So very chronic use of NSAIDs, right? That is over the counter. If you buy non-steroidal anti-inflammatory agents, right? In some countries, they are just over the counter, right? You can buy them without a prescription. Those can cause kidney disease, right? Chronic kidney disease, and that can cause hypertension. And then among those are also oral contraceptive pills, which can very, very rarely cause kidney disease, right? Which somebody asked me a question why OCP is not indicated. So that those can cause problems with the kidneys as well. So drug-induced nephropathies, right, are the fourth group, which I forgot actually, right? So 4 things you need to remember, at least to name them, and at least to know what investigation needs to be done, right? Is that clear? Any questions so far? Right, one moment. Right, okay. So we are talking about renal disease, which you need to have an overview, right? The next large group of causes that will cause hypertension in pregnancy are the endocrinological disease, right? So which you will need to know the names or what conditions, how they present slightly, right? Thank you. Thanks. Sorry, one moment. Right. Oh, sorry for the interruptions. I'm, getting calls, right? All right. Okay. Endocrine disorders, right? So endocrine disorders, right? You have to know these by heart. I really don't need to teach them to you all, right? These are all student material, but I will just tell you. What is the first thing is primary aldosteronism or Conn's disease. So that serum potassium low whenever plasma aldosterone, you have to diagnose with the plasma aldosterone renin ratio. So all those, they have myalgia, weakness, headaches, features of the potassium and the hypokalemia. So all the things which you know, which can go. So this is all the bread and butter of the endocrinologists and the physicians. They love doing all this. This plasma aldosterone renin ratio, Conn's disease diagnosed, mineralocorticoid. So it's due to mineralocorticoid excess. So therefore, they will love diagnosing all this, right? So then they will write to us with happiness. I have diagnosed, Conn's disease, and then this and that and all. Okay. The next is Cushing's. You understand that Cushing's will cause it's glucocorticoid, right? So what you have to understand is Conn's mineralocorticoids, when it excess, it's Conn's. Okay, එක states වල. Glucocorticoid වැඩි වුණාට පස්සේ excess states are Cushing's. හරිද? ඕක තමයි ඉතින් දැනගන්න ඕනේ. ඉතින් what is the diagnosis? You do 24-hour cortisol. එහෙමද කරන්නේ, right? So therefore, what will they have? They will have thinning of skin, recent weight gain. What is this? Echo, they would have been on some form of steroids, polyuria, polydipsia, skin changes, skin thinning, telangiectasia, all these things which you have to you have to say tak thingy, right? That you have to know all these things so that now you know your Cushing's. Then the other favorite one with the physicians now is with pheochromocytoma. How does it read? Paroxysmal hypertension, right? And it is associated with very severe headaches, right? Then they have tachycardia, severe headaches. Then again the pressure goes down, right? When you measure the pressure, it's 220 by 130. 290 by 140, very high pressure, and then suddenly it goes by now. So how do you diagnose it? In the plasma, you can check for the metanephrines, or urinary, you can check for vanillin mandelic acid, right? So these are the things that you can do. So what are the other states that you need to know? Now, we have done primary aldosteronism or Conn's. we have done Cushing's, we have done pheochromocytoma. Then one of the commonest things, I had a case recently, also parathyroid disease, right? Thyroidism, so hyperthyroidism or parathyroid disease can cause what? It usually causes hypercalcemia. Suddenly, I had a patient who has been severely hypertensive. Finally, we diagnosed hypercalcemia, and it is parathyroid disease, right? And therefore, you have to do thyroid functions tests, parathyroid hormones, calciums, and all that. It's very difficult to control actually. And you get pregnancy, then you get hypertension, then you get preeclampsia. They will have preterm delivery, lots and lots of problems, right? And they get eclampsia sometimes. It's very, very difficult sometimes to have, because parathyroid disease sometimes it's very difficult to control. Finally, they might need surgery for them to, you know, because my patients who had nearly died, right, until we diagnosed this, and then she miscarried, and then finally she had a surgery, and then she had a proper pregnancy without any problem, right? So they may be having, it might be associated with thyroid disease, where she has features of hyper or hypothyroidism, right? They will have sometimes the eyes might be coming to, that is, what is that called? Where we can have where the eyes will bulge out sometimes, right? They will have tachycardia, sweating, sleeplessness. All this can cause due to features of hyperthyroidism, right? Then acromegaly can be a rare cause. Carcinoid tumors can be a rare cause. So these are the ones which we have to understand are the endocrine. But these, remember, these are the physicians will definitely diagnose them. And one of their favorites is diagnosing a cause of hypertension, which should be, as medical students, your favorite pastime as well, right? Then next comes this type of ECA is due to neurological problems, right? And what are these? Sometimes tumors, brain tumors due to space occupying lesions can cause children hypertension, right? They will have sometimes they will have different kinds of paralysis, right? Visual disturbances, and then all cause of cerebral problems. And of course, we'll have to diagnose that by MRI or an ultrasound scan of the brain, which may be life-saving, because sometimes they will come with fits and you think it is eclampsia, but blood pressure is high, they have fits, you think it's eclampsia, actually it may be a brain tumor, right? And therefore that can cause problems for the patient. Then of course, one of the things that is coming up very rare is sleep apnea, right? But usually they are very, very large patients with a large history of episodic apnea, and that can cause mega. So of course, overnight we need to do the sleep apnea test, which are done overnight, sleep test, where they have the machine and you sleep, and then the apneic attacks may be calculated, right? So those are the things. Sometimes spinal tract injuries, all these things also can cause paraplegia, all this can cause. And the final thing is coarctation of the aorta, right? Where the students need to know what the famous radiofemoral pulse delay that can diagnose this. So these are the basically what we need to understand about the causes, which if you, I have, what is this? I have listed out the causes, right? What you have to do is, children, just list out the causes, right? If you, it's not a difficult thing. You have essential hypertension, you have renal disease, which is normally 4, which I told you about. You have endocrinological disorders, right, which is about 6, 7, and finally neurological disorders, right? That will be found in any book, any MBBS, right? These are the things which you have to find. In one column, you put the names. In the other column, please write the features, right? In the other column, you write the diagnosis. Okay. So if you do get so 3 columns, just put in a table, right? You will find these tables in most of the books that you can, your MBBS books, right? So that you can use when studying for, if a patient with chronic hypertension comes, remember, if there's a patient with chronic hypertension in the ward, we will give it, okay, right? So for the exam. So therefore, you need to know that it is different from a pre-eclampsia or a pregnancy-induced hypertension, which we'll do later, right? So now let's look at the medication. Now, how do we treat? So now there is a patient with chronic hypertension or essential hypertension, so in a pregnancy. What are the principles of treatment? Principles of treatments are few. Number one, right, the target blood pressure values is to keep the blood pressure below 150 and the diastolic below 100. Okay. If the blood pressures are constantly over 160 and 110, we really need to bring it down, right? Or if it is even higher and we can't get it down, then of course we might have to think of delivery. So basically the target blood pressure values are something to keep everything by between, say, at least the systolic between 150 and 140, at least the diastolic between 90 and 100. Okay, those are the target values. If the blood pressures go very low with our treatment, less than 110 and less than 70, we need to think whether we need to reduce or take off the dosages which you are using, because that will cause hypoperfusion of the placenta, and that can cause problems with the fetus. So therefore, the target values are not very low pressures, not very high pressures, because that can cause increase in our problems. So we try to keep it around those figures. Is that clear? Next is, in pregnancy, it's a short duration, right? When they come, if they come at 10 weeks, we have about 30 weeks, right? And we might deliver earlier. So we are not going to, we cannot make them lose weight. Okay. So it's not practical for them to lose weight and expect the pressure to go down, right? We might not be. So it is always, remember, exercise moderate is all right. Trying to lose weight is not an option really in pregnancy, right? So we can, general measures like reducing salt intake might help a bit, right? However, usually for chronic hypertension in pregnancy, it is always medication, okay? And the medication which you need to avoid are what? Number one, what are these? Angiotensin converting enzyme inhibitors, right? And angiotensin receptor blockers, 2 types of medication. The third type of medication, or those are both angiotensin and receptor blockers and the around angiotensin. The next one which you need to avoid are what? Chlorothiazide, right? Which is a diuretic, which can cause fetal problems, right? And the fourth type is what? The fourth type here are beta blockers. Okay. So those are the, sorry, one moment. Right, sorry. Okay. Medication, right. So the second principle for chronic hypertension is not to combine. Okay. Is to go with monotherapy to the highest dose possible, and if only it's not controlled, to add on a different kind of medication, right? And we do not add different same class medication together. For example, we do not add nifedipine and amlodipine. Okay, so we try to add different classes and combine them. So this medication, what we try to do is we try to go with monotherapy. Second thing is we try to increase the dosage to the maximum, and then only we will try and add on a different acting drug, right? And what are the common safe drugs in pregnancy which you need to know? So remember, please put out a graph for yourselves. Type of drug and its mechanism of action, which I will tell you now. Second thing is how it's given, the dosage normally from what to what it's increased, and how safe it is. Those are the common things that a MB-based student will be asked for. For postgraduates, we will ask more, right? For y'all, that is more than enough for any question to ask, right? The main kind of drug that we have been using over time is centrally acting drug, which is called alpha methyl dopa, right? You all would have heard of the drug. It has one of the best safety data of all antihypertensives in the world for pregnancy, right? It has been there for a long time. It has been used for a long time. It has been found extremely safe, and then it has the longest safety data after the baby is born, and the babies or children have been followed up for a long time to find out whether, so until they became very big. As I think Ogolange Vayas Vitara wage wenakamma ewa follow up vela thiyena methyl dopa, right? So, but it's oral. You can start from, it's normally a 4 times daily dose. Some use 3 times, but it is normally 4 times QID. You can start from 250 milligrams QID to up to about the maximum about 4 grams even of methyl dopa, right? 1 gram QID when come methyl dopa. However, the problem with methyl dopa is it can give fatigue, it can give depression sometimes. It can get, the patients can get sleepy on it, right? They can become lethargic, right? These are the problems. And therefore, remember, postpartum, we don't give methyl dopa. It's contraindicated because it can exacerbate depression and psychiatric disorders sometimes, especially depression. So therefore, we do not give it. However, during pregnancy, it's very safe. Babies can get a bit of hypertension sometimes. Neonates blood pressure by now, but usually it's a very safe drug. So it's a centrally active, mole act karanne, a drug. Then the safest beta blocker that can be used, right? It's actually a alpha and a beta blocker. A combined one is labetalol, right? It is the only drug among beta blockers or pure beta blockers neme, like atenolol wage wa atenolol neme, what is this, what is the beta blocker that we commonly use, children?
Propranolol.
So propranolol we don't use. Atenolol, labetalol and atenolol we try to avoid but can be used. So labetalol is a drug which can be used safely because it's a combined alpha and a beta blocker, right? So this, the only problem with beta blockers, remember, is that they can cause bronchoconstriction. So you need to be very careful if the woman has asthma. So try to avoid that. If the woman has asthma, it can cause bronchoconstriction, right? And however, as far as the baby is concerned, it is safe, right? So therefore, labetalol can be used oral. It is used intravenous during preeclampsia and eclampsia, right? Right? So therefore, labetalol can be used. Even atenolol can be used. But remember, it has to be used with caution in when a patient is having asthma. So it can cause asthma to become more severe if you use it, right? The other thing which you can be used is prazosin. There is safety data, but we hardly ever use prazosin because it's an alpha blocker, a pure alpha blocker, right? But however, it can be used if necessary during pregnancy, right? The next group of drugs which are used are calcium channel blockers, right? What are these? Very 3 commonly ones are what? Nifedipine, right? Next is amlodipine. And especially when there is problems with heart problems, right? With tachycardia, all those things, verapamil also can be used as one of the calcium channel blockers, right? So all these, all the drugs which I told you all does not have any fetal problems, right? Sometimes, so atenolol, remember, can cause growth restriction, low blood rate, right? But however, most of the other things has no association with fetal problems. So methyl dopa is supposed to be safe, labetalol is supposed to be safe, atenolol also can be used, right? Prazosin also can be used, nifedipine, amlodipine, verapamil, all those, there is no problems with the fetal. So therefore, you can use it. Amongst the diuretics, remember, the only medication that should not be is what? Chlorothiazide, right? So chlorothiazide we do not use. So remember, that can cause fetal anomalies, fetopathy, and possible problems with some thrombocytopenia, all those can be used, so we don't use it. Furosemide we try not to use because it can cause imbalances, hypovolemia, and it reduces the intravascular volume of blood, right? And therefore you can have thickening of blood. So therefore you can have, so furosemide we try to avoid furosemide, although there are no problems with the baby, right? And then vasodilators, we use hydrolysine, right? However, hydrolysine is normally used as an acute hypertensive for hypertensive crises to try and get the pressure down. So those are the ones which you need to know. Remember, again, if I remember, what are the drugs that can be used? No single drug has been found to be superior to the other drug, right? All the data. This can be compared with this, that has been compared with this, and then so it has not been found to be superior. So basically, for the moment, all these drugs can be used. In your minds, what you have to know, remember, children, remember to classify the drugs that are used in chronic hypertension, which are what? Centrally acting, methyl dopa, right? Beta blockers, labetalol, right? Atenolol, we rarely use, right? However, it can cause, like other beta blockers, like propranolol, it can cause low birth weight, right? Then we have alpha blockers, processing can be used, but rarely used. Calcium channel blockers, we normally use 2, nifedipine and amlodipine. Amlodipine is rarely used, nifedipine is commonly used, and verapamil is used in heart conditions for beta blockage, but that also can be used if necessary, right? Commonest problem with calcium channel blockers is ankle edema, right? They have headache and ankle edema, right? So therefore, that is the commonest problem. So all these drugs have no problems with the baby. Amongst the diuretics, normally this is not used unless, but normally chlorothiazide is not used because it has abnormalities, congenital, do not use it. Furosemide also we try to avoid. And the last group are the vasodilators, which we use hydrolysine, but that can be used for a long time, but usually because there are tablets, but usually we use it as intravenous to get the pressures down. So that is all, children, you need to know about the medication that needs to be used for what? For pregnancy. So remember, all these are drugs that can be used. Just check on the doses, that is for your everyday use. Commonly used ones are methyl dopa in Sri Lanka, methyl dopa, labetalol, right, and nifedipine. These are the 3 very commonly used drugs. I have told you what drugs should not be used, right? Remember that. And these 3 drugs are, at least for these 3, you will need to know the mechanism of action, which I told you already. You need to know the dosages from start dose to end dose, right? And then you need to know that we can combine sometimes labetalol with a calcium channel blocker, which is possible. You need to know a few of the side effects. The common ones in, remember, labetalol is exacerbation of asthma. In methyl dopa, lethargy, increase in depression, and all that. Then in the labetalol bronchoconstriction, which I told you about. Then in nifedipine, headache and ankle edema. ඒටිකම තමයි complaint කරන්න nifedipine දෙන්න පටන් ගත්තාම. So those are the things that you need to side effects. බබාලගේ වෙනස්කම් එන්නේ නැහැ, no problems, right? The ones that give බබාලගේ වෙනස්කම් are what? Chlorothiazide as a diuretic, contraindicated. Atenolol, which we hardly ever use, but if it is used, can give growth restriction. So those are the things that you need to know about when you are talking about drugs in pregnancy, and that summarizes the total amount of drugs in pregnancy, right? So the next thing is, remember, as time goes on, they can develop pregnancy, preeclampsia. And what are these preeclampsia? They can, so with chronic hypertension, they can have preeclampsia. And how do you diagnose that? The diagnosis, sometimes what happens is there's a rapid increase in hypertension, right? And sometimes the proteinuria will sometimes increase, right? And also at the same time, other things like liver function test will increase, which we'll all discuss during when we are talking about the management of preeclampsia. So those will come as new things. So therefore, you might be able to, on top of hypertension or chronic hypertension, you might be able to discover that it is what is this? Now it's preeclampsia and not just pain. So one of the things to avoid it is what? Is first to give aspirin at 150 milligrams from the onset of after 12 weeks. The second thing is trying to predict it by uterine artery Dopplers, right? See the notch, everything is a bit of a problem which may not be very exact in prediction of preeclampsia in chronic hypertensive patients. Okay, so those are the things that we need to understand. Next is, how do we deliver? Usually, we do not offer delivery as a routine if the blood pressure cannot be controlled. If the blood pressure is uncontrollable and it is always elevated over 160 diastolic and up to 170, systolic more than 160, diastolic more than 110, what happens is the chances of fits, cerebrovascular accidents go up and the mother can die. And therefore, if it is not controllable, we might offer delivery. But other than that, if the blood pressure is less than 160, 110, right, and it is in the controlled range which you talk about, we do not deliver until 37 completed weeks. Okay, and beyond that, we can discuss with them, and then probably we will deliver around 38 weeks, right? So after 37 weeks, so we do not deliver them before 37 weeks, right? But after 30, we deliver before 30 weeks only if there's a problem. If not, then if it is below 160, 110, we can keep them until about 38 weeks, right? And deliver them around that time. So the timing of delivery is decided by our control of blood pressure and how well it's controlled without any end organ damage, or even if it is controlled end organ damage, then we will think of delivering only after 37 weeks. 38 weeks seems to be a suitable compromise, right? Then that is delivery. How patient is delivered is a normal vaginal delivery or cesarean section, depending on what we can just for obstetric reasons only, right? And however, refractory chronic hypertension, if it's not going down with whatever medication, then you might need to, of course, deliver, but then you have to give steroids before delivery. Okay. Postpartum, how do we manage after delivery? After delivery, every day for the first 1 or 2, 3 days, you need to measure blood pressure, right? And then this is all chronic hypertension, right? Then every second, third day, then you can, when do we deliver? In chronic hypertension on proper medication, we deliver. If the blood pressure is between less than 150 and 110, on medication, patient can be discharged. This is different from preeclampsia, okay? This is chronic hypertension. So anything, if the blood pressure is less than 150 systolic and less than 110 diastolic, on medication, you can discharge. If it is a newly diagnosed patient, right, and the blood pressure is less than 140 and less than 140/90, a newly diagnosed patient with medication, with what we have controlled it during after delivery, right, on medication, we can discharge it. What are the things which you can use? Remember, methyl dopa needs to go out. We do not use methyl dopa after delivery because that can cause fatigue, hypertension, lethargy, and increase in depression. So therefore, we take it off. the safest ACE inhibitor to use is enalapril. That is the only one that does not has safety data saying that what it is safety data showing it does not appear in milk, breast milk. So enalapril can be used. The other drugs that can be used are without any problem in breast milk, right, is labetalol and atenolol. Labetalol has the best effect after pregnancy, which can be used to 100 to 100 milligrams. You can use it BD twice daily or even 3 times daily, up to 600 milligrams 3 times daily. That is about 1,800 milligrams a day, right? 2 to 3 times a day, right? Common doses are about 100 BD, 200 BD, 200 TDS, like that. You can go up to about 1,800 milligrams like per day, right? And then if the woman wants a single daily dose, because labetalol you have to take 2 to 3 times a day. If you prefer a single daily dose, then you can go with atenolol, right? Remember, in pregnancy we don't give it, but after pregnancy we can give it. Atenolol causes, remember, it's a beta blocker, can be used with caution, but it can cause the baby to be small. So therefore, it can. So during pregnancy we try to avoid it, but however, in after pregnancy it can be used, and it can be started from about 25, 50, 75, 100 milligrams a day as a single dose. That also can be used. Okay. The other thing that can be used after, this is after delivery, postpartum, is nifedipine. Nifedipine SR can be used 10 BD, 20 BD and all that after delivery to control blood pressure. You can use amlodipine, right, which can be about 5 to 10 milligrams. And so those are the medication that we can use, amlodipine, nifedipine. There are different types of nifedipine now. There is SR, sustained release, then modified release, then different kinds of medication that has come up, so which can be used in different types. Amlodipine has the advantage of using it as a single daily dose. Nifedipine SR දවසකට දෙසරයක් දෙන්න, right? Nifedipine MR කියලා එකක් තියෙනවා, ඒක දවසකට එක සැරයක්, which can vary. Okay, so therefore you can choose whatever you are familiar. However, calcium channel blockers can be used. Then the other thing is, the only medication that can be used, the ACE inhibitors, right? Angiotensin converting enzyme inhibitors. The only ACE that does not have what it is that does not appear in breast milk in large quantities is enalapril. So therefore, enalapril can be used in the dose of 5 to 20 milligrams twice a day, right? Which can be used for breastfeeding mothers. So in conclusion, the 4 types of drugs which can be used is what? Labetalol can be used, which I told you. Atenolol can be used. Nifedipine SR can be used. Amlodipine can be used. Nifedipine MR can be used, single daily dose. Okay. Amlodipine also single daily dose. Of the beta blockers, labetalol is 2 to 3 times a day, but the single daily dose is atenolol. And then the only angiotensin enzyme inhibitor is enalapril, which we can use, right? 5 to 20 milligrams twice a day can be used, right? So those are the things that you need to understand. Right? Remember, after delivery, other ACIs, that is angiotensin converting enzyme inhibitors and ARBs, angiotensin receptor blockers, cannot be used, right? They are not recommended because and the diuretics should not be used after delivery, right? So those are the postpartum things that we need to talk about. And of course, remember proper advice, and then they need to be handed over back again to the physician for to be looked after, and then they come back to our preconceptional clinic for another discussion if they want to go ahead with another pregnancy. Okay, so that is basically what I wanted to tell you all about, right? Any questions that you want to know? Okay. So as I told you, it's a short topic. I don't know how short it was, but I think I didn't take much time, right? So it's a topic that you need to understand, right? So this is the first lecture in hypertensive disorders. Next time we will probably, I don't know, maybe I should continue with preeclampsia and all the other things, right? So I think it's a logical follow-up. So, and we'll do gynae afterwards, right? So let's see. There's a question. What is the mode of action of aspirin at 12 weeks? Well, why we use aspirin is that we think that it reduces aggregation, right? It is thought that placentation, because of its action as a blood thinning agent, right? Therefore, in lower doses, it causes less aggregation, right, of blood, and the coagulation becomes slightly less, and therefore it is thought that the placentation, or it helps the trophoblastic invasion, right, of the placenta, and therefore, because the trophoblastic invasion is the problem with preeclampsia, the placenta is sick, and therefore the placenta becomes ischemic, and therefore ischemia of the placenta produces certain chemicals which damages all the organs of the body. This we are going to discuss anyway, right, in the next lectures. And this causes damage to all the epithelium, and therefore that causes preeclampsia. So therefore, if you make placentation and trophoblastic invasion more better, right, due to the use of this, it is thought that the preeclampsia incidence will go, because the placenta becomes more healthier in women who it might not be due to their predisposition towards preeclampsia. How do you antenatally follow up the patient? But I thought I answered that. It's a normal follow-up, right? However, in these patients, we measure blood pressure more frequently and at least once a week, right? We need to be measuring blood pressure at least once a week, so that so it is blood pressure monitoring. So they can monitor it at home if they want. They can get it monitored by a doctor, right, or a midwife. So it's blood pressure monitoring that should be done. And we don't really need to do specific tests, but we need to continue the medication and make sure that the blood pressure does not fluctuate. Is there a place of increase the dose of calcium supplements, and what's the reason to do so? There were some articles, but these studies were very, very small, where it was thought that what happened was there's I think only one, right, which was done long time ago, where the calcium supplements were increased quite a bit, right, and that showed a slight reduction. Actually, the paper said it reduction of preeclampsia 50%, but since then it has not borne any. The credibility is not there. It's a small paper, and therefore still that is quite a controversial topic. So we do not give a very huge dose of calcium just to avoid preeclampsia. So for the moment, there were a few papers, there were some recommendations earlier, but now it is not very practiced regularly. What is the drug used during labor to control the BP? Right. All these it's the same, right? The patient will continue whatever medication is taking, which I discussed, right? There are some things that end. However, if there are acute hypertensive crises, intravenous labetalol is good. Intravenous hydrolysine is good, right? So these are the two drugs that we can use to reduce the blood pressure in and hypertensive crisis, because they can be used intravenous. However, all the rest of the drugs can be continued throughout the labor, because as I told you, the drugs which I told you have no much or does not have any problematic side effects on the fetus. The only thing is fetus can have hypertension sometimes for the first 1 or 2 days, right? Would you please repeat why prazosin isn't used much in pregnancy? Because we don't have much experience on that, and because there are better drugs, right? Now, prazosin is a alpha blocker, right? And therefore, we normally we have a alpha and a combined beta blocker, which is labetalol. So therefore, prazosin alone is used very little. So we don't have, although it's safe, still we hardly ever use it. It's not because it is not used, it can be used, but certain medications have been found to have more data and more common use and easily available, right? And therefore those drugs are used. Do we continue aspirin until the time of delivery? Yes. Is there a place to do placenta growth factor values to rule out preeclampsia? Placenta growth factor, not really. So, all these are experimental, right? And we can't, now preeclampsia is not going to be ruled out by placenta growth factor values, right? Preeclampsia is something that you will diagnose, right? And we are not going to diagnose it with placenta growth. These have a value in sometimes the prediction, but we hardly ever use that in it. But we will speak about all these in preeclampsia. Because remember, today's topic is chronic hypertension in pregnancy. Okay, so it is, I gave you an overview of chronic hypertension and not preeclampsia. Okay, the mechanisms are different in preeclampsia, causing hypertension. However, in chronic hypertension, the chance of preeclampsia increases. Okay, and that is why we anyway start aspirin in these patients to reduce that incidence, right? Okay, so we'll discuss preeclampsia when we are going to discuss preeclampsia later. Okay, all right. So I think, any more questions? Okay, I think you all have run out of questions, so then we will. Yeah, whoever is remaining, can you all tell me what you all want me to continue? Do you want me to continue preeclampsia and hypertension, other hypertension, or do you want me to switch to a gynae topic? Quickly type in what you all want. One or two. Finish ops, continue, sir. Finish preeclampsia. I wish I can finish these things. Right, okay. Okay, so they want PIH. Okay, fine. Right. Okay then, understood. So we'll do preeclampsia next, right? Preeclampsia and other hypertensive things. Right, okay. Okay then. Good night.
Good night.